Good morning again, and it's a pleasure to be here since you guys probably will order these tests more than us in your lifetime. So in the next half an hour, we'll try to review some, first part will be mostly definitions and terms, and the next part will be questions, board simulated questions for stress testing. So why do we use stress testing? One of the reasons we use stress testing is the issue of diagnosis, prognosis. You treat the patients, you want to see how they responded to therapy. Patients with suspected coronary artery disease with risk factors. You have patients with known coronary disease coming for follow-up. You have patients referred for non-cardiac surgery. You want to make sure that you know what's the risk during the surgery. And we learned recently that there is little we can do to modify that risk, even if we know they're at risk. Before and after cardiac revascularization, you have the patient that Dr. Menon presented with the totally occluded circumflex coronary artery. Probably the right choice for that patient would be, now 4 or 5 days after the infarct would be to have a non-invasive imaging modality to figure out if there is residual ischemia in that territory, and then you can base your decision on revascularization depending on the results of the nuclear stress test or the stress echo. The issue of, this will come on and on now on the boards, the issue of special populations, especially women and diabetics. There's a lot of focus on that. Post-myocardial infarction, as we've seen in the previous session, and evaluation of chest pain syndrome, as you saw in the last question that Dr. Menon showed you. Now, what happens during stress testing is you increase the O2 extraction, the myocardial workload by about 3-folds, 4-folds. It depends how far you go on a treadmill. Most of our patients usually increase it, but actually it goes down by just sitting and asking for a chair before you put them on a treadmill. You increase your systolic blood pressure, your mean arterial pressure. One important thing is, and it's been now studied extensively, is the diastolic blood pressure should remain unchanged and with a very small amount of variability. If it actually goes up, that's a predictor of deconditioning and poor outcomes. You have a reduction in mean maximum predicted heart rate with age, as well as with use of medications. And post-exercise, our institution and many others have shown that the return of heart rate to baseline, how quick that heart rate return to baseline, is a very important predictor of outcomes. So people who can actually bring their heart rate back to normal baseline quickly, these are people who are very well conditioned and they have a good prognosis versus people who have a prolonged period in the post-exercise period of tachycardia. Now, let's start with some of the modalities we have, and we go over some of the advantages and disadvantages. So what's important about exercise stress treadmill test, which has no imaging with it? It's very cheap. It assesses the functional capacity. It's been studied for prognosis for years and years and years, has over 40, 50 years of assessment of prognosis with this modality. The equipment, every place has a treadmill. Many offices in the community have treadmills, so it's not doesn't require this high-end technology. And the accuracy is tested in many populations, in males, females, young, old, post-MI, pre-revascularization, post-revascularization, diabetics, non-diabetics, and so on and so forth. Now, the disadvantages of this modality are important because they focus on the sensitivity. The sensitivity of this test is lower, so you could miss some coronary artery disease by even if the test is normal. The specificity is determined by having a normal EKG. If you have an abnormal EKG at baseline, and the abnormal EKG is defined here as STT changes, digoxin abuse or use, left bundle branch block, pacemakers, the female population, the specificity of the test would go down. So if you have a positive test, the likelihood of this test being true positive is lower. Now, the other thing with the stress testing is often, even now in our practice, you see the fellows coming to me and say, oh, this person had ST depressions in 2-3 AVF indicating inferior ischemia. Actually, the localization of ischemia by this type of test is not so good. So if you are planning on targeting revascularization to a vessel, You cannot use just a stress test to do that because you need some imaging modality to guide you where the ischemia is happening. So EKG is, stress EKG alone is not enough for that. Now, what about the risks of that kind of these tests? The risk is extremely small, 1 in 2,500 or less. And the important thing about this test is the absolute contraindications for the test. So you can have a patient with an acute MI within the past 48 hours. This test should not be performed. If you have a patient with unstable angina, so if you tell you a question on the boards, the patient is coming with chest pain, EKG changes, that's not the first test you want to do or the last test. If you have patients with cardiac arrhythmias, not atrial fibrillation, but we're having patients with VTAC, patients with WPW, stuff like that, you don't want to do these tests. If you have a patient, and it's important here, symptomatic severe AOS, asymptomatic aortic stenosis is not a contraindication for stress test. But if the patient is showing up with syncope, with chest pain, with heart failure, these are not the patients you want to put them on a treadmill. If you have uncontrolled heart failure, these patients, it's common sense, you're not going to put them on a treadmill. Pulmonary embolization, myocarditis, pericarditis, and acute dissection. These are the categories probably they will ask you about on the board. They give you a presentation like that, and they will tell you, would you order a stress EKG on this patient? And the answer, even with an imaging modality with it, it's no. You don't want to put them on a treadmill. Now, the interpretation relies on few things. It relies on the pretest likelihood of disease, which is the clinical presentation of the patient. The hemodynamic changes is the patient blood pressure rise appropriately, drop with stress test, which is a bad prognostic sign. What's the EKG response to the stress test? And mainly, do you have ST depressions of more than 1 millimeters? I'm not going to go into details how to read an EKG stress test, but these are generalities of how you interpret them. Now, the sensitivities and specificities we'll go over in the next couple of slides are derived from comparison of the EKG results, the treadmill result, with an angiogram. The sensitivities reported in literature are modest, 60 to 73%. So in any patient you're testing, you could be missing severe coronary artery disease or significant coronary artery disease in about 30 to 40% of the patients. The same thing with specificity. In patients who have a positive EKG stress test, you can have anywhere from 20 to 40% of these tests as false positives. So it means you call them positive, you go to the cath lab, and you find they have no disease or no significant disease. So what's the true value of this test? I will show you in the next couple of slides. So here we are. This is a meta-analysis of 147 studies looking at EKG stress testing involving over 24,000 patients. And you can see here the sensitivity of these tests is about 68% overall, and the specificity is much higher in the high 70s. So if you're looking for a value for EKG stress testing, is not to pick up ischemia, is actually to find ischemia and be sure that it is there in a cheap way. Now, how does this compare with other tests we have? So if you look at the common tests we use, which is here you have in yellow stress EKG, in green you have the stress echo, and in red is nuclear. You can see as the radiation exposure or the complexity of the test goes up, you gain some sensitivity here. So EKG would be for single vessel disease about 50%. Nuclear will be in the mid 80s for picking up ischemia. And as you go along, you can go patients with triple vessel disease. There is not much difference between among the modalities for picking up ischemia. So it depends what you're looking for. But in general, as you accelerate the deployment of the technology, you have a higher sensitivity. Now, what about specificity? And this is general specificity for the stress test. When you call it positive, does it turn out to be positive in the cath lab? You can see is actually stress EKG, despite the bad rap you get from cardiologists about for it, it's actually intermediate between nuclear being very non-specific. So we often get called from the cath lab, you told us this test is positive by nuclear stress test, and about 3 in 10, you have the test is actually false positive. EKG is slightly better than that, regular EKG stress testing, and stress echo is actually the best among these three modalities. Now, the other thing they might ask you about is the Duke treadmill score, and I'm not going to waste a lot of your time on how to calculate and stuff like that, but this is a very important prognostic marker. Every stress EKG lab, as far as I know, reports this. It's validated in both men and women, and it's not validated in the elderly. It takes into account the duration of the exercise, the amount of ST depression, and the anginal score, how much angina you have on the treadmill, and there's a formula that you can pull it up on Google and check it out, but it will be available in your slide set when you check out later this week. So how does it work? If you have, this is the 4-year event for a Duke's treadmill score. If you have patients here with in red with a Duke treadmill score of greater than 5 plus, you have mortality event rate at 4 years is almost non-existent. And as the Duke treadmill score rises, you can see the event rate skyrockets. So it's a very important predictor. It's used in almost every single stress EKG lab. If you decide to have a treadmill in your office, this is an important thing to report, and it's an important thing to prognosticate from it. Very important. The other thing I want to talk about is a negative EKG stress test. And this is extremely important. I will repeat it through the questions I'm going to show you later. A negative EKG stress test is very important for prognosis. The higher the METs you achieve, the better your prognosis. And even, we're not talking, you're eliminating CAD by going far on the treadmill. About 55%, this is from the meta-analysis I showed you earlier with EKG stress testing, about 55% of patients who have achieved higher than 10 METs on the treadmill will have significant coronary artery disease. And it depends on the disease, on the population you're studying, but in patients with suspected CAD with high, let's say, Framingham risk score, a significant number will have a CAD, but yet their prognosis is excellent. So it depends what you're using the test for. You're using it for prognosis or you're using it for diagnosis. If you're using it for prognosis, the number of METs count. Now, what are the class 1 indications for an EKG stress test? Important for initial risk stratifications in patients with normal EKG, patients with established CAD, but with some change in clinical status, low-risk patients with unstable angina who have no active angina at the time or heart failure, and in patients post-MI after the last angina episode. Now, we shift gears here. We go to the MPI, myocardial perfusion imaging, nuclear stress testing. Well validated. The results are very reproducible. If you show these results, these tests, multiple cardiologists to read them over time, actually the concordance is very high. It can assess the left ventricular function. It has improved sensitivity and specificity in general. And it's more accurate determinant of the extent of CAD. I cannot tell you how much you have CAD from a regular EKG stress test, but from this you can establish you have single vessel disease, double vessel disease, multi-vessel disease with high accuracy. And it's used for assessment of myocardial viability very often. Now, the disadvantages, it's expensive. It's getting cheaper with declining reimbursement, so don't worry about that. In the future, we'll be doing them for free. It requires long-time commitment, not on the part of the physician, but the part of the patient. The radiation exposure for these tests is in the range of, Dr. Menon put it in millisieverts, but I can put it for you in X-rays. If you take a nuclear stress test with technetium, you're talking about anywhere between, depends how you dose it and stuff like that, 500 to 1,000 chest X-rays for a nuclear stress test. So just think about that when you bring your patient every 6 months for a nuclear stress test, and which we see a lot, and we try to prevent it, but whatever. So we have artifacts with it. It's actually plagued with artifacts. Surprisingly, it works very well. I read these for a living, but it has actually reading the artifacts is more difficult than reading the test itself. It requires a lot of equipment upgrades, personnel, all these things, and it has problems when the patients have left bundle branch block with a lot of false positives. With all these things in mind, if you have a normal nuclear stress test, your event rate, as you can see here, if it's called normal, whether it's in an academic center, the community, or whatever, the event rate is very low, under 1%. So you can actually decide which route you're going to follow with your patient based on the results of nuclear stress tests. So for those who are normal, they can just be treated medically. Those who are mildly abnormal can probably be treated medically. And those who are severely abnormal can go to the cardiac catheterization and get revascularization. Even this is now being questioned, actually, this strategy. But for the general idea, this is what you should do. What about the stress echo? Stress echo is, you talk about it the same way, imaging modality, assessment of myocardial ischemia, higher sensitivity and specificity than regular EKG stress testing. It only provides, not only provides information about ischemia, it provides information about LV function, valvular heart disease, the pericardium, the aorta. You can see many things with a stress echo you cannot see with a nuclear. The nuclear is basically a perfusion map. The stress echo is actually a total anatomic image of the heart with the right ventricle, left atrium, all these things. So very often we get surprised, we send the patient for a stress echo for ischemia and we find other things that we did not find. So it's a very good screening test. It has no radiation in it, very important. And it's the time commitment on the patient's part, which is about 20, 30 minutes for the test, is different than nuclear, which is 3-4 hours to get a nuclear stress test done. However, the problems with it is the interpretation is subjective. You can get few physicians in the room and ask them about the stress echo, and they might disagree on many aspects of it. So it's a very subjective interpretation. The images can be non-diagnostic, especially in very obese individuals, and this is more than 50% of the population these days. It's the prognostication from stress echo is not as well established as nuclear stress testing. The numbers usually quoted in literature is in the thousands for stress echo and the hundreds of thousands for nuclear stress testing as far as number of patients enrolled in studies. So it's not as well established. It has the same problems with left-bundle branch block. You can have this wall motion abnormality in the septum that you cannot interpret as ischemia versus just an effect of the left-bundle branch block. Now, a certain percentage of your population, it's a growing percentage, will undergo not stress EKG, not nuclear stress testing with an EKG. These patients will undergo a pharmacological stress test, basically with an agent that mimics exercise or a vasodilator in general. These are very well-established technologies. It's been probably now as well established as EKG stress testing. The disadvantages is you cannot assess the functional capacity from these modalities, because these patients are basically, we call them going to the spa. They just lay on the table, we inject them with the stress agent, and then we go on. So there is no functional capacity assessment with these patients. They can have problems with hypotension, a lot of side effects of these medications because they're not physiologic in general. What about the Dobutamine Stress Echo? Probably they will not ask you about this on the board, but I have to put it in for completion's sake. It's as good as exercise stress echo and assessment of ischemia. It can be used for assessment of myocardial viability. It has, like stress echo, you can assess also the valvular heart disease, aorta, left atrial size, left ventricular size, and all these other things. The problem is it cannot assess functional capacity. If you're looking for functional capacity, you're not going to see it here. The EKG part of the test is not as, the results of the EKG part are not as well established as far as prognostication as stress EKG. So the changes there are in general non-specific. Now, it requires, as with stress echo, extensive reader experience, labor intensive, and it's contraindication in many subgroups of patients. And it can be a problem because the heart rate never returns back to normal for minutes and minutes after the test, which can sound like hours. So these are all the modalities we have, and you have to choose from when you're faced with a patient presenting to your office. Let's start with the first case, a 38-year-old female with mild obesity. As it's planned probably by the Cleveland Clinic now, we refer these patients, we probably force them into an exercise program so they can save on their insurance payment. So they come here, she wants to lose weight. She has no other known risk factors for CAD, and this is what you recommend. Exercise stress echo, exercise SPECT, treadmill stress test, proceed to exercise program with no further testing. So most of you actually got this. This is great. So most of you got this right. So here are the guidelines, the ACC/AHA guidelines for stressing asymptomatic people without CAD. There is no class 1 indication for this. So as far as the boards are concerned, you're having a patient coming for routine stress testing. There is nothing called routine stress testing in asymptomatic individuals. Now, they make an exception for diabetic patients, with known risk factors. These are who are planning to start an exercise program. For routine screening, it's actually a class 3 and it's not recommended. The next one is a 73-year-old male patient with elevated cholesterol, hypertension as risk factors for CAD. So he has age, cholesterol, hypertension, asymptomatic, describes himself as very active. His life insurance asked for an exercise stress test to assess his prognosis. His EKG shows normal sinus rhythm with left bundle branch block. You inform this patient that you can proceed with the test for the above indication. The ability to test the test to predict prognosis is compromised in this instance by the presence of left bundle branch block. Prognostic information can be only derived from a pharmacological stress test in this instance, or the insurance carrier should pay for a CT angiogram. Because we just got a new machine, we might have to use it. So most of you chose, I'm glad I put this question here. So remember, this is a test indicated for prognosis. And whenever you want to get prognosis, you have to look at functional capacity. The presence of left bundle branch block doesn't matter here. In patients who are undergoing stress testing, the things that can compromise the test are the presence of pre-excitation like WPW, V-paced, widespread ST depressions, or left bundle branch block. Now, in these patients who have these problems, the stress test can be still used for prognosis, but not for ischemia. So the right answer for this is for prognosis, you can still put the patient on a treadmill and stress them. You're getting the prognostic part of the test. So just remember that what's the indication for the test? As I told you earlier, are you diagnosing CAD or you're checking for prognosis? So this is the two studies that looked at that, and the most important part is the duration of prognostication of a stress test, or the duration of exercise on the treadmill, and the number of ST depression, leads with ST depression. So again, just keep in mind, they want you to assess prognosis with length of exercise or period of exercise on the treadmill. The next one is a 56-year-old female patient with a BMI of 29, presenting for evaluation of atypical chest pain. She has known elevated cholesterol and hypertension. Her resting EKG shows normal sinus rhythm and T-wave changes. You recommend pharmacological stress test, nuclear, exercise treadmill test with SPECT, and treadmill test with an echocardiogram. So most of you chose the echocardiogram, and we'll see what's the correct answer. So the answer here is, the correct answer is treadmill. Pharmacological stress testing with nuclear, this patient can walk. Why should you switch her to a regular test or to a pharmacological stress test? So that's not indicated. The EKG on this patient has only T-wave changes. That's not a contraindication for a exercise treadmill test. So only contraindications are, or if you're worried about lower specificity, is if you have ST depressions. So although in this female population, and they will ask you that on the boards, I said for the general medicine boards about 3-4 years ago for the recertification, they ask you about this on because there's this misconception in the community that females should not be sent for an exercise stress test. Every exercise stress test should be combined with an imaging modality. That is not true. So just be careful with that. So baseline T-wave changes do not affect the specificity of the stress test, even in females. So keep that in mind when you're ordering these tests. The next one is about the elderly, and I'm choosing these specific populations because they focus on them on the boards. 76-year-old male with atypical chest pain, hypertension, ex-smoker, presenting for evaluation prior to traveling overseas on vacation. You recommend an exercise treadmill test. His resting EKG shows LVH. Now, you have to keep in mind that exercise treadmill test in this population is known to have a higher sensitivity, similar accuracy compared to younger population, lower specificity, or all of the above. So all over the place, which is again very good for me because I feel like I'm teaching you something. So you have here, most of you picked lower specificity, and they probably because of the LVH. The answer for this is all of the above, and let's go with these one by one. So the sensitivity of this test, always the sensitivity of test depends on the pre-test likelihood of disease. In the elderly, the prevalence of CAD is higher, so the sensitivity is going to be higher for the test. The next thing is the specificity is lower because of the presence of LVH. You can have, so whoever picked this is correct. And the accuracy has been tested, and it's comparable to the general population. So all these answers that I put there are correct for this elderly population. Two more questions. 57-year-old male with severe mitral regurgitation in the setting of posterior mitral valve prolapse. He reports no symptoms. Ejection fraction is 65% with normal EKG, normal LV function, and dimensions. Treadmill test to assess his functional capacity was considered. Your medical student, being a smart guy, suggests that this approach is not supported by the guidelines, because they read the guidelines more than any of us. You responded that the functional assessment in this patient with valvular heart disease carries a class 1 indication because you were on the guideline writing committee. Class 1 indication is only for patients with aortic stenosis. The treadmill would be useful for diagnosing CAD in such population, or none of the above. Again, a widespread. That's very good. So there are no guidelines supporting stress testing patients with valvular heart disease as far as the literature is concerned. Asymptomatic patients who have valvular heart disease, there are no class 1 indications. So on the boards, they will not ask you about this. So that's the other thing. Now, for diagnosing of CAD in patients with valvular heart disease, it actually carries a class 3 indication. So remember, on the boards, they have this binary thing, either class 1 or class 3. They will not ask you a lot on class 2A, class 2B, and stuff like that. So you have to know what's indicated and what's almost absolutely contraindicated. So you cannot use them for, you cannot use stress testing in patients with valvular heart disease, period. Now, this is the next question. 71-year-old male patient underwent 3-vessel CABG 3 years ago. He presents to your clinic for evaluation, establishing care in this area. He reports no symptoms. He describes himself as very active, swims 4 times a week and bikes twice a week. You complimented him on this exercise regimen. You told him you're doing a great job. His wife, who's a former head nurse, asks you if you're planning a routine stress test. She also tells you that she gets this every year when checking with his former doctor. So what did you tell her? There are no guidelines for routine stress testing in patients who are asymptomatic post-revascularization. The ST changes on the stress test are more predictive of future angina, but not events. ST changes on the treadmill are not accurate for localizing ischemia. Treadmill can be useful if he develops new symptoms, and all of the above. Wow, that means you learned something during the session. Great. So most of you got this right. This is all these points we've made throughout the talk. Routine monitoring for these patients is not indicated after revascularization. It carries actually a class 3 indication, which is basically not recommended. They only recommend them when the patients have new symptoms after revascularization, and that's a class 1 indication. So just keep in mind the few points. If they tell you on the boards that the patient stopped the exercise stress test because they jumped off the treadmill or they fell or something like that, you cannot use this test for prognostication. So, and then they tell you the prognosis of this patient is so and so. Just keep in mind, you have to complete the stress test and stop it for an indication, basically symptoms, ST changes, drop in blood pressure, to derive the prognostic information from the stress test. The heart rate change with the stress test is important to assess cardiac function and deconditioning. If the effort is poor, even if the nuclear stress test or the stress echo or whatever modality they're using to tell you, if the effort is poor, if the METs are under 4, 5, that's a bad prognostic sign. So don't be swayed by the results and normal results of the imaging modality to say this patient is low risk. Focus on the effort part of it, the METs achieved. And if the METs are high, if the patients achieve a high MET rate, 7, 10 METs and so on, the imaging part of the test becomes irrelevant as far as prognosis. It's important for diagnosis, but not very important as far as prognosis. Thank you.